any viral infection, because very often we don't know which one we have. Is it COVID? Is it flu? These people really have to be careful.
So you pointed out elderly is a big population right there. Number two is all the people with diseases. You just name an organ, and then that's it. If they have a disease in that organ, they count as a high risk. So we have diabetes, kidney disease, lung disease, heart disease, any of those things will put you at higher risk.
Welcome to the Expand podcast, where we unlock the secrets of respiratory health for healthcare professionals. Join leading experts as we dive into chronic lung diseases and expand your practice.
I'd like to welcome you to this podcast with Dr. Peter Lin. You don't want to miss this opportunity, trust me. We're going to talk about family physician. And this is a topic that we really need to give the value back, to family physician, how important they are in our healthcare system and how they can turn this healthcare system into what we need for the patient. Let's not look at other solutions than having the right people. And you're going to see we have the right people here in this podcast. Peter Lin, talking about family physician and COVID-19. Peter is Director of Primary Care Initiatives at the Canadian Heart Research Centre. He's a passionate speaker, and he has given over hundreds of lectures. He has been guest editor for the magazine such as Focus on Cardiology. He's also consultant for Perspective in Cardiology and serve on the editorial board for the Canadian Review of Alzheimer's disease and other dementias. He was one of the author of the vascular protection section of the Canadian Diabetes Guideline in 2013 and 2018 and has served on the editorial board of Pri-Med Institute USA, which provides education for physicians. Dr. Lin also received a teaching award from the College of Family Physicians of Canada in 2011. Let's welcome Dr. Lin on this podcast topic of COVID-19 from the family physician perspective. Thanks, Peter, for being with us and giving you time and this discussion that we're going to have together.
Thanks very much, John. Your podcasts are fantastic, so I'm very glad that you invited me on.
Thank you. We should have invited you before, but I know Peter very well. We've been working together in different situations, and I've always enjoy and learn, which is important from many of our colleagues. Thanks, Peter. But always kind of questioning why have you decided and what drew you into family medicine?
Well, it's interesting. So family medicine, you get to do everything, right? So think about it. You become a respirologist and a cardiologist, endocrinologist, neurologist, pediatrician, geriatrician, and that's just the morning, right? In other words, every 10, 15 minutes, every patient, you need different sort of skill sets. And so the thought is, why not use those different skill sets? So you get to have like a buffet. So think of family medicine as a buffet of medicine where you get to, do many different things. And then this is the only profession, I think, where we could see somebody, basically going from baby to when they're very old and retiring. So I think it's very fulfilling that way. So it's a buffet for us, but also we get to look after many of our patients over their whole lifetime. And being able to do that is actually very rewarding, to be able to see children bring in children and so on and so forth. And I think that's really the beauty of being in family practice.
Being a specialist, I have so much respect for my colleague, family physician, because I can hide behind the one disease or limited to a system where a family physician cannot. You have to know kind of so much. And what I like about you and many family physicians have been working with is that you can give a value to your work and what you're doing, and we have to realize how important it is to have family physician in the healthcare system. There are not enough family physicians. We have to give the value to being a family physician, and people are going to listen and they're going to see what it is about being a family physician and how you can be a good family physician. the landscape, as I'm just saying, is quite wide. Okay. And then if you had to tell us about a journey of a family physician and how family medicine has changed over the years.
Yeah, it's evolved over time. So I remember when I first started to become a family doctor, back then it was still, you could be a general practitioner, but now we have the specialty of family medicine. And we now also have other people that are helping out in primary care medicine. So, for example, nurse practitioners, pharmacists, educators, they're now all part of this huge team because we now realize that in primary care, you could look after many diseases. Therefore, you can prevent the need for secondary care, tertiary care, and those kinds of things. So I think the emphasis is on looking after people, making sure that they're healthy, and prevention. And so I think in the beginning, family physicians were seen as, I don't want to use the word lowly, but in other words, there was the specialists who knew a lot of information. The primary care was able to take care of the basic things. But over the last 30 years or so, we're seeing many new studies, many new medications, many new guidelines that are now distilling the information down and saying that in primary care, you could look after these things. So nowadays, for example, not only do we look after lipids and blood pressure and diabetes and heart failure and COPD, we're looking after the more severe stages of these things because we now have medications that are simplified enough and the guidelines are simplified enough that we can apply that to our patients, which then allows our specialty colleagues to go after the tougher and even harder patients to treat. So basically, the information pyramid is coming downwards. So therefore, the primary care doctors are now taking care of many more people within that pyramid, and therefore allowing our specialty care to give even better care for those really sick people at the top. And so I think the role of primary care and sort of family medicine has gone from prevention of disease, which it's still very important, to managing some of these more complex conditions. And who better to quarterback this than somebody that's looking after the heart and the lungs and the kidneys and everything else, because it's all coming into that one spot. And therefore, the specialty care will be sort of our extra support in those areas as we need. But basically, we can now, have a very sort of comprehensive care for our patients in the primary care setting.
And what you're saying is very important, Peter, because the specialist is obviously take care of the patient, but it's more about an organ where we are very specific to, and that's where the area, and there are subspecialty even in the different system in respirology and cardiology, where the family physician has the whole perspective, more in terms of the patient than only in terms of the disease. And he has to integrate different disease condition, okay, with the well knowledge of the patient, who that patient live in a family, that patient live in a society, and so on, okay, and so on. Then it is quite an important responsibility. It's not only about triage, it's about taking care of patient. And the stratification is now changing as family physician work in group. Then you see more and more of these responsibility, which make the profession quite interesting, I would say. Would you think so?
Yeah, I think it's more rewarding because now we get to do more things, right? And as you were saying, now that we have these teams of people, so we have dietitian, pharmacists, nurses, and things like that, now basically we can take care of most of the needs of that patient. And it's only when those systems fail or the system of the patient fails that then we would need to go on into, let's say, specialty care and hospital setting. So we're trying to shift everything away from the hospital-centric kind of care to let's take care of the patient in their own environment. The other thing is, as you were saying, as we cross over multiple organ systems, what we're finding is that there are many similarities, right? So inflammation is the same system among system and so on and so forth, right? So in a sense, it makes it easier when we start going across all of these system organs.
And it's hopefully they are physician or they are resident or a student that are in training in medicine that are listening to that podcast, that they are going to think about, I should be going in family medicine. We need family physician, and we need good family physician. We already have many of those, but we need more. And the journey can be quite variable. And you can choose within, now that there's group of practice, you can choose. And and now they may have more affinity for certain thing, where this is something you can do now as part of a group, where before people were practicing more in solo, and that was more limited. And then you have access to the other healthcare professional that you can really, because most of the disease that are treated nowadays are chronic disease, isn't it?
Yeah, exactly. So all of them are chronic diseases and not these episodic things, like infections and things like that. And so therefore, this chronicity is what we're looking at providing care for. In other words, it's not just I take care of you for this moment, it's I take care of you for the duration. And as we understand the disease process, as you pointed out in respiratory diseases, can we prevent those diseases from occurring? So now we're getting better and better at preventing diseases from
Yeah.
occurring, and for sure the complications of those diseases. If we think of diabetes, for example, we're preventing the complications of diabetes. And therefore, patients don't end up in hospital, and they don't end up with 5 or 6 different specialists looking after, the vasculature and the heart and the brain and so on and so forth. So I think that's why the primary care now, the government is seeing it as being the cornerstone of therapy. And then we use the specialty care in those situations where we need that extra assistance. And so that's why the cornerstone is really still primary care. And that's why it's such an important profession for people to consider.
Let's go into another area of medicine that has been quite important, and unfortunately the last few years, it's the COVID-19, where we knew very little about it just a few years ago, and then finally April 2020 it became official by the WHO, that we were in pandemic. Now we're in the endemic, and what hasn't changed in family medicine, COVID-19?
Well, a couple of things. I still remember when everything was shut down. We basically didn't want to see any patients for fear of the virus and things like that. Now, since then, we've learned a lot about the virus. And in a weird way, family practice was perfectly positioned for this virus, because this virus goes through the ACE2 receptor. Everybody kind of knows that. And we know that the ACE2 receptors is found in many different tissue systems, right? So many different organs have ACE2 on their cells. And so basically the virus can then access many different organ systems. And that's why we have 100 different symptoms for long COVID, for example, because this virus can go into all these different places. And so that's why, in a sense, primary care was actually ideal for this. Because instead of sending, you have palpitations and therefore you go see this person, you have this, you go see this person, the primary care physician can look after that. During the acute phase, it was actually quite scary, because basically we had no treatments, we had no vaccines. Basically, you're relying on your immune system to do its job. And we saw horrible things with the elderly and so on and so forth.
Yeah.
So in the beginning, it was a bit helpless for us. But as we learn more and more, we realize that primary care is in a perfect position to look after these people. We know about vaccinations, we know about treatments, we know about the different organ systems. So we were more able to cope and manage these patients. So in a weird way, I think COVID-19 showed us how primary care is so important. In terms of looking after these patients, even during a pandemic. And where do patients turn to? They turn to pharmacists because they were open, and to their primary care physicians. And so that's really where the information was coming from. And I think that disease and the pandemic highlighted the importance and the work that the primary care physicians do every single day.
You've been talking about something that the population or people listening should probably understand, because we didn't understand that from the beginning. But you've been talking of the ACE receptor and why the COVID make this respiratory viral infection so different than other respiratory viral infection. Let's take the example of influenza. And what would you have to tell us about this, the difference between the two?
Yeah, it's very interesting. So everybody kept saying, well, COVID is just like the flu, so it's no big deal. The flu virus, all viruses are the same. They have become so evolved that all they carry is a set of blueprints, and a set of keys to get into your cell. That's
Mm-hmm.
all they carry, right? That's all they have is blueprints on how to make themselves and a set of keys. In the case of the flu virus, the set of keys opens up the sialic acid receptor. So it attaches to that and then it gets into your cell. Once it's in your cell, it can use your photocopy equipment to make copies of itself. Now, the sialic acid is mainly found in the lung. So therefore, when you breathe in the flu virus, basically it's going to stay in the lung area because anywhere else it cannot attach and get into your cell. So his
Then
keys,
it's a lung
it's a
disease
lung
then.
disease, right? So it's the
Okay.
keys. They only have keys to open up the lungs. That's it.
Okay.
With COVID-19, that spike protein, because it goes after the ACE2 receptor, ACE2 is found in many parts of your
Okay.
organ systems. It's found in your lung, in your brain, in your kidneys, in your pancreas, in your blood vessels. The lining inside the blood vessels have ACE2. And so therefore, this virus now has access to all those different places. So imagine a master key. So now the virus has a master key that can get into these places. Yes, it goes through your lungs to enter into your system, but once it enters your body, it could go to the brain, the pancreas, your GI tract, and
Interesting.
those kinds of things. And so that's why initially we all heard about the lungs. People couldn't breathe. Then we had people with a very bad sore throat. Then we had people with couldn't smell, and then we
Mm-hmm.
had people with diarrhea. And we're going like, what's going on with this virus? It seems to be changing because depending on where the virus ends up going with the set of keys, those will be the symptoms that you have. And so therefore, COVID-19 is different because its set of keys is like a master key that can get into all these tissue organs. And that leads to the fact that if it can get into those organs, it can cause damage and so on and so forth. And I think that's why we saw the acute phase of the infection very different. So initially it was no breathing issues, then it was sore throats, and then it was no smell, and then it was diarrhea. And that's why this thing was wandering around, because it has the ability to get into all of those different cell types within our body.
That has been a painful learning experience. Although we know a little bit more about this virus, we still have a lot to know, and we're kind of moving now into the long COVID, where and this is an area where we kind of discover a lot of things, and it seems that we have very little to offer. But why is it so important? Okay, that we know better from a mechanistic point of view, and then in terms of managing these patients, what would you say, Peter, about the long COVID and where we stand now?
And this long COVID business, I mean, in primary care, this is where we see the patients coming back. So they get past the acute COVID infection, and then now they have these lingering symptoms for, weeks and months on end. And the problem is we're treating long COVID as if it's one condition, right? We say long COVID, and then we say, oh, by the way, long COVID has 250 different symptoms, right? So obviously it's not the same. So the question is, what is causing long COVID? Because then we can figure out the treatments for it, right? So that's, I think, the important thing. So that's why I think we shouldn't cover it all as long COVID. And I've seen different patients coming in. So for example, we have some patients that come in are short of breath after their COVID. And if you look at their lungs, they actually have damaged lung tissue. So one way that we can keep symptoms going is if we damage the organ. So if we damage your lung tissue, then you cannot breathe, and therefore you're short of breath. Okay. Now, number two is, let's say the virus is still replicating inside your body. See, we're assuming that the virus disappears, but they've shown that about 10 months afterwards, they can still measure that spike protein in the blood of some of these long COVID people. So could it be that the virus is hiding somewhere and still producing, and therefore your body is still responding to it?
Kind of become a chronic disease due to the virus.
Right?
Yeah.
Exactly.
Wow.
And then in that case, your therapies would be different, right? So if you're producing virus, then I should give you something to stop the virus. So antiviral might be a good idea. What happens if it's your immune system has gone crazy? So this is the idea that there's no more virus anymore. And we saw that with the kids with this multi-system inflammatory syndrome where they couldn't find the virus, but their body was still attacking. So your immune system has gone a little bit crazy, and it continues to fight a war that maybe it's not there, and therefore
damaging your cell this time instead of fighting against a virus that has disappeared. Yeah,
exactly. So now all of a sudden, for those people, then maybe we should focus on giving medications that suppress your immune system, right? What happens about the diarrhea? These people with diarrhea, bloating, these sort of stomach pains. We know that the virus can get into the lining cells of your bowels. but we also know that it could change your microbiome. Those are all the good bacteria that help us digest food, get rid of chemicals, help us absorb good chemicals. This is our good citizens, that we want to keep functional. And when they looked at patients with COVID in hospital, for example, and they looked at their stool, their poop, basically, they noticed that the bacteria changes. The types is different. And if you change the types of your good bacteria, then that means maybe later you can't process the food, you can't absorb things, and then you're going to have long-term symptoms because your nutrients is now being tampered with as well. Now, those people, maybe we have to focus on how to give them back the good bacteria, right? As opposed to, antiviral therapy. So you can see that each group of people have a different mechanism, and therefore maybe the treatment would be different. I know there's one area where they've been looking at small blood clots happening. So you can imagine, I said the lining of the blood vessel, that lining is like Teflon. It's supposed to be smooth. Those cells that make that smooth surface have ACE2. So if the virus goes in there and damages the lining cells, then now the lining gets damaged and your body thinks, this is like a cut. So it will form blood clots on those areas to seal it up. Now, if those blood clots clog up those small blood vessels, then there's no blood flow. And then you will have symptoms of whichever organ is not getting the blood flow. So that's why some people are saying maybe we should give blood thinners, to stop that process and to allow that lining to heal up again. Now, obviously, if I have stomach bloating and you give me blood thinners, it's not going to help.
Bleeding.
Right? Yeah. Same thing. If I have blood clots happening and you change my diet, it's not going to help. So that's why in my mind, as a primary care doctor, because I'm seeing these different people coming in, I need to figure out what is the mechanism and then figure out the treatment. For example, we've heard about POTS. So POTS is this idea that when you stand up, your heart beats fast and you get dizzy. So people cannot work. And so it turns out we have a control system that helps us stand up. So when we stand up, Jean, basically all our blood goes to our feet. And so then your head will not get any blood and you'll get dizzy. So our body has a system that squeezes the pipes in your legs. So therefore, as you stand up, the blood cannot all go into your legs. So therefore, you still have blood going to your head. So you can stand up and not be dizzy. It turns out the virus can go into that control system and maybe make it not work so well. So if it's not working well, when you stand up, there's no squeezing of your leg pipes. Therefore, all the blood goes to your legs and then you get dizzy and then you can't stand up and you cannot work. So for those people, we try to think of what should we do? So right now, we don't know other than to keep the virus away. I think that's the first thing. But what we could do is if your heart is beating very fast, we give you medicines that slow it down. So we give you beta blocker. If the blood is going into your legs, we give you stockings, those compression stockings.
To prevent
your leg, right? So then the blood doesn't go down. So what we're trying to do is say, what is the mechanism of your long COVID? It's going to be in one of these buckets. And then number two is how can we figure out a study to help us understand what we should do? But in the meantime, do we have any medicines or ways right now that we can help you? So let's say your lung is damaged and you're wheezing and you are short of breath. Well, Jean, you have very good puffers. Yeah. We could use the puffers and things like that. We could help them do respiratory rehab where they practice their breathing. And those would be good things. So I think that's what we're trying to do with long COVID is divide them into groups that looks the same, that share the same mechanism. And then we could do studies on them to see what is helpful. And then in the meantime, we use whatever we can to try and help those patients sort of at least be able to live. It's a horrible thing. And that's what we're thinking about right now for long COVID, at least from the primary care perspective.
That's obviously very sad that these diseases happen. But at the same time, the explanation you're giving are quite indicative because it makes things very satisfactory if you take the time to see that every patient that have long COVID may be different. And if you are able to tackle those differences, then there are some support treatment that you can start looking at. And in the world of research, and the research might be done differently now and not seeing all these patients being the same, but looking at mechanisms, and therefore new treatment might be coming in the future where we're going to have a solution for it, because some of these patients are just desperate and their life has changed like unbelievable. I'm sure you've seen some of these patients.
Yes, very much so. And as to your point, is that if we can just spend the time to tease out those symptoms, I hate those studies that say, long COVID study, and then you look, there are 150 symptoms. That is not helping me. Okay, it's not going to help my patients either. So I think if we can tease those things out, it's good. And I like reading the research around some of this stuff, right? Because then it's exciting because it's like a mysterious black box. And all of a sudden you shine a light in it for a split
Yeah.
second. You could see something, right? And you say, there's something in the corner. There's something here. And I think if we just keep shining that light a little bit, collect these people together is good. One that I've seen very much, Jean, is the tired, the fatigue, the no
Yeah, that's
energy, the
is.
brain fog. And that one is so difficult. So I was reading these papers. I have no life, so I read these research papers. And it was
Or you
about
don't sleep much.
yeah,
Okay,
yeah, that's right. Yeah, that's right. I that's my excitement. That's my Netflix, I guess. But there was one paper that was very interesting. It was about the mitochondria. So the mitochondria is the power plant inside your cell that generates energy for your cell. And it turns out this virus is very smart. It comes in to the mitochondria, and the mitochondria normally burns two kinds of fuel. One is sugar-based, and one is fat-based. The sugar base does not require oxygen. It's your quick energy. It's like get up and quickly go. And then the fat is the more enduring sort of, if you want to keep running, that's the fat that you have to burn. Now, it turns out if you burn the sugar, you don't need oxygen. You can just burn the sugar quickly. If you burn fat, you must use oxygen to burn the fat. So this virus is very smart. It comes in and it flips you to burning sugar. So by flipping you to burning sugar, it does not rely on oxygen. And remember, it might have destroyed your lungs on the way in. So oxygen may not be around very long. And so therefore, it flips it across to just burn sugar, and then I can make energy so that I can run the factory, so I can make copies of the virus. So very smart. Cancer cells do the same thing. So in cancer, when it grows very fast, maybe the blood supply not so good, maybe not enough oxygen. So those cells flip over and burn sugar to stay alive. So the virus does this very nicely, flips it over for you and makes the virus copy. Let's say you get rid of the virus, but let's say the switch is still on this side. Now that's a problem because all you're going to do is burn sugar, which only gives you that quick energy, and you don't go into the fat burning. So that's why a lot of patients will say, I'm good for about a minute or two, and then I'm a mess.
I'm dead, just
exactly.
so fatigued.
So it exactly explains this mechanism. Now, the beauty of this is that they've done experiments looking at the mitochondria in these people. And if you look at healthy people, mitochondria is like this. If you look at normal pneumonia, mitochondria like this, so they're the same. If you look at COVID, it's like this. So in other words, there's definitely something going on with our power plant. And my frustration, but also hope, is that this virus, the blueprints, only makes 29 proteins. So the whole blueprint only makes 29 proteins, and that's it. 4 of the proteins are for structure. It's for the shell, it's for the spike protein, all these structural things. So that means 25 of those proteins are doing these funny things in our body. And so the question is, which one is going into the mitochondria and flipping? Because if we can figure out that protein, then we could figure out how to unflip that scenario. And therefore we can offer hope. Because remember, this long COVID with this sort of tired fatigue thing hits about 90% of the people with long COVID. So the majority of long COVID have this. The other thing that it might explain is the brain fog. The brain cells require many mitochondria to keep it going. It needs a lot of energy. And so therefore, if this flipping of the switch is happening in those mitochondria in the brain cells, then the brain has no power, therefore it cannot send signals. And that's why patients are saying, my brain feels like it's running slow, like it's slow, it has no energy.
I cannot learn the way I used to. I cannot remember things. Yeah, it's kind of...
So that's why I'm hoping that the research, 4 years out, I still cannot name the 25 proteins and say which one does what. And I'm hoping that we can spearhead some of that kind of research. And
why some people have it and other, because the majority of people don't have it, in fact.
That's right. And therefore, there's a genetic component. And that's why the last part that I would like to see is what is special about the 10 or 15% of the people that get this long COVID business. Like, what's different about their genetic code? And the way to do it is kind of like looking for the needle in the haystack. So I should take the genetic code from this long COVID, this long COVID, this long COVID, this long COVID, and then see what's the same. In other words, anything that's different between these people, we ignore. what is the same, and then we could figure out what gene is the same, and perhaps we can identify people. But I guess I think from my perspective, I'm hoping the research will head in this direction so that we have more clarity instead of saying long COVID is a big problem and they keep giving us, about 15% of the people get it. They're telling us each infection increases your risk. So the Canadian data basically says first infection, about 15% of the people get long COVID. Second infection, about 25% of the people get long COVID, and 3 or more infection, it's 35%. So
That
1
is
in 3
much
people.
higher.
Right. So therefore, there's an accumulative effect. And in my simple way of thinking, every time there's an infection, you have to fight the war. Like your body has to fight.
Yeah.
And you have to keep this virus from entering all these sacred places, like your pancreas and your kidneys and your gut and your lungs and so on and so forth. And so that's why it's so important not to get the infection in the
Let's
first place.
talk about, Peter, because that you're touching something so important. Let's talk about the way we can treat the disease, or the best way we can treat the disease. It's by preventing
Yes.
the disease, or preventing the complication. What should we be doing? Okay, because do we have prevention treatment?
Right. Yeah, you're absolutely right. And we're right back to primary care and what we do, right? Which is preventing disease and avoiding the complications for our patients. So COVID-19 is an example of diabetes, really, right? That's what we're trying to do. Prevent diabetes. If you get diabetes, let's prevent the complications. So the same thing with COVID-19. Don't get COVID-19, but if you do get it, how do we minimize the effects on
the
that particular
complication
patient?
and so on?
So it's very simple stuff, right? So we know the basic. Let's go back to really basics.
Yeah, please.
Is that this virus has evolved so well that it only carries blueprints and the set of keys, right? So it has no way to move. So there's no mobility from this thing. It doesn't carry an engine. It doesn't steer, because it knows that it just needs to make copies on you, and you will bring it to the next person. You will breathe it on grandma, and grandma will suck it in. And so it knows that it does not need to have any kind of propulsion, right? So all viruses like that, RSV, influenza, a COVID, anything that you name that is airborne is relying on that fact that we will bring it to somebody. So
they're stupid. We have to be brilliant.
We're social.
As human beings.
Jean, I'd rather say we're social as opposed to stupid. So what I'm thinking is step number one, don't breathe on grandma. Okay. And number two is don't suck in the air from other people, right? So if grandma wants a hug from the little kids, then tell grandma to hold her breath. The kids hold their breath. So the virus is not moving at that moment. And so that's level number one. You could still get the hug, just don't suck in the air. Level number two, the mask is helpful because it slows down your sucking of the air. So in other words, the virus must be much closer before you can actually suck it in. It's not so much that it filters it, it just keeps the air that you're breathing around you as opposed to this big air that you're sucking in. And it stops you from blowing out the virus. So that's level number two. Level number three is, let's say the virus gets into your body, then I would like to have an army that's ready. And I would much rather have an army that's ready as opposed to building the army as the virus is coming in.
That's your immune system.
Right. So that's where our vaccinations is so important, because we can give you a heads up and say, hey, this is what it's going to look like. So build an army now. So you could stop it at the border so that it doesn't go into your lungs and then your pancreas and all these other things before you can respond. This virus can replicate very quickly. So therefore, we don't have a lot of opportunity to stop it from entering all these places. The other thing is that we get older, we lose our thymus, this thymus gland that they kept saying, you don't need it, you just need it as a kid. Well, we do need it. Thymus is where, the T cells, right? The T cells are named thymus. That's the T. But T cells are made from your bone marrow. Okay. But they have to get training at the thymus. So think of Harry Potter going to Hogwarts to get training. That's what the thymus is all about. So basically the T cell goes to the thymus, and what is it training? It trains for two things. Number one is make a receptor that can recognize an antigen, like something that you've never seen before that might attack you in the future. So how do you do that? You assemble your Lego parts in different ways. So if I give you 10 pieces of Lego, depending on how you put it, you can make different receptors, right? So therefore, the first step is make a receptor that is useful to recognize something that we haven't seen yet that you can defend us against. If you can make one of those, then you pass. If you cannot make a receptor, then that T cell is killed. Number two, that thing that you just made cannot recognize yourself. If it recognizes yourself, then you're going to attack yourself, autoimmune disease. So
Disease,
the
yeah.
second test is, do you recognize yourself? If you recognize yourself, that one is killed as well. So of 100 T cells that go into your thymus, only 2% come out fully finished with this. But those 2% is very important. They can recognize things that you've never seen before, and they are not recognizing yourself. So it's a perfect army for you to protect you. As we get older, unfortunately, we lose our thymus. It gets filled with fat, apparently. So by the age of 60, 85% of it is fat. Okay. So therefore, we don't have that nice system where we can pre-build these receptors that can recognize many different things. So that's why if I'm an older person and I get the virus, I don't have any predetermined T cells that can recognize that. So therefore, I have to make it on the fly. And let's say the virus is growing very fast, can kill me in 3 days, but it takes me 5 days to make the antibodies and the receptors,
Yeah,
then I'm going to lose. I'm
it's
going to
too late.
lose.
It's
And that's
no,
why we
it's
saw
too late then.
with
Yeah, yeah.
COVID, it was the older people was getting into all sorts of trouble. And so therefore, that's why the vaccination strategy is good. So layers, right? So I talk about hockey, it's hockey, so you have the different layers to protect you, right? So therefore you have defensemen, you have distance, and so on and so forth. And then the goalie is your antibodies. That's the one on the inside. So once the virus enters, then you will need some defenses in that way. So that's why if we do the layered protection,
That's
I
where
think
the
that's the best
vaccine
way.
are still so important, but they're part of a preventative approach. Okay, and and when we look at our patient, and some of the patients say, yeah, but I don't need the vaccine, or the vaccine, give side effect. There are risks associated with the vaccine, and what would you answer these patients?
Yeah, I think the key thing is always risk benefit, right? I get into a
Yeah,
car. Can I have a car accident? Yes, I can have a car accident, but the benefit is I get to go to where I need to go to. So we're always weighing risk benefits. And yes, there are some people that have side effects, just like there are some people allergic to peanuts, but it doesn't mean peanuts are bad. It's those people and the peanuts together are bad. So now that we've had so many billion vaccines, I think people are
yeah,
quite
it's
comfortable with
billion.
it. Right. Yeah. So with a B, like huge numbers. But I think the most important thing to remember is to give that heads up, especially in the elderly population, because they're not able to mount a response fast enough. And I
Okay.
think that's why, even though right now the virus count is very, very high, like if you look at sewage data, there's a lot of virus floating around. But we're hoping that we will not have the deaths that we were seeing before. And that's really our goal, is to prevent the complications. So if you do get the virus, we don't want those bad complications to happen. And I think that's why we have to still be vigilant with all of this, the mask and the
Yeah,
distance and all
yeah.
those things, and also the vaccinations and also the antivirals as well. So if you were to get the infection and you're at high risk, perhaps those medications that stop the virus from fully assembling itself might be a good idea. So it buys you time. And basically, it's buying you time so that your body can then mount that response. So the whole idea is to give you as much of a head start as possible against this particular virus, because it can enter too many different rooms. And we've now noticed from the US Veterans Database, if you get COVID number one, let's say you're an older person, you get COVID number one, then cardiovascular disease risk goes up by about 20 or 30% of
Wow.
heart attacks and strokes and blood clots and things like that. If you get 2 infections, then it goes up higher, and 3 infections
Yeah,
goes
yeah.
up higher. And the severity of it. So let's say you went into hospital because of COVID. Now you're talking about 200% increased risk of those bad things in the future. If you were in the intensive care unit, now you go up to maybe about 600% increased risk of these things. So the numbers are astronomically high. And that's why we would like to avoid allowing this virus we just don't want you to fight the war. And if you do have to fight the war, I want you to have, some good equipment, and antivirals and things like that to back you up as well.
And people have to remember that obviously we don't want to go back to the lockdown like we had at the beginning of the pandemic, where there were we didn't know much, we didn't have vaccine. Now we have to socialize with the virus. It's more of an endemic than pandemic. It's there to stay. That we have to learn to avoid. People have to avoid when they have any viral infection, because very often we don't know which one we have. Is it COVID? Is it flu? Is it even a
RSV, yeah.
rhinovirus? No, we just don't know. The vaccine, okay, is preventing the complication by what I'm hearing you. Therefore, you say, okay, the elderly, but is there condition where people that have comorbidity or certain condition that we would also want to say these people really have to be careful? More attention has to be given to these people in terms of vaccination and or in terms of treatment if they have the infection.
Very much so. So you pointed out elderly is a big population right there. Number two is all the people with diseases. And if you look at the list, you just name an organ and then that's it. If they have a disease in that organ, they count as a high risk. So we have diabetes, kidney disease, lung disease, heart disease, any of those things will put you at higher risk. And the way I kind of explain it to my patients is that I was reading these other papers talking about we have an auto-destruct sequence in our body. So in other words, the cell, if it detects a lot of damage or it detects a lot of virus, it will kill itself. And it's good for two reasons, right? If the cell is very damaged, then you should destroy it and let a new cell come. And if it's lots of virus in there, you should destroy it so the virus can't move around. So therefore, your body will detect two things, damage and also virus count. And if it's too high after a certain number, I guess, then the cell will say, I need to kill myself to protect the rest of the body. And so when the virus came in to a sicker person, let's say you have COPD or cancer, or you've had a stroke or something like that, where there's already damage. So now the cells have damage. If I add a little bit of virus to that, you can trigger that auto-destruct, where the cell will say, I need to destroy myself, and it will call the army to come and kill itself. And this is known as a cytokine storm, where it'll call things over to destroy itself in order to protect the rest of the body. Now, this is fine when you're talking about 1 or 2 cells or 10 cells. But let's say you have 1 million lung cells that are now with disease plus virus triggering this call for action, the cytokine storm, then you end up destroying your lung. And this is why we saw in the people with comorbidities, they were at much higher risk of
complication,
right? Hospitalization, death, and things like that. And that's why you saw people using steroids. Because people were crazy. They said, why are you using steroids with a viral infection? It's because we don't want your body to do that auto-destruct sequence. And that's why when you were really sick, they would give you a huge dose of steroids to shut that down. Say, don't destroy yourself, okay? Not necessary. And that was helpful for people, and it saved people's lives. If I were to give you the steroids too early, like they did in India, all we got was fungal infections.
And the virus load, where you have the virus load at the time, then you make things worse. Yeah,
exactly. So this is by not understanding. That's why we get into trouble. So that's why I think we have to understand this virus into what is triggering. So therefore, if you are elderly, if you are, let's say, 80, you have more damage in your cells to begin with. And so that's why I think the elderly are at very high risk. Then if you have any other condition, cancer, diabetes, heart disease, stroke, those kinds of kidney disease, you have more damage in your system again. And so therefore, if we add a little bit of virus on top, it's going to push you over that auto-destruct sequence. We then saw something interesting with Delta. When Delta came along, it was able to grow at 1,000 times faster than Wuhan. So the original virus, this thing can grow 1,000 times faster. And for the first time, we saw in healthy young people getting into intensive care unit. And that's because the virus goes in and it can replicate so fast that it makes enough virus that you trigger this auto-destruct sequence in a healthy people. I don't need you to be old. I don't need you to have diseases. I can grow so fast that the cell will detect too much virus. I have to kill myself. And like I said, if you have 1 million lung cells doing that, you're going to end up in the intensive care. So that's why we're so afraid of these new versions that they keep saying it grows faster. It grows faster, because that's why we have to pay attention. So that's why when people say, no, COVID is done. No, COVID is not done. COVID continues to evolve. And as it evolves, it will still bring it to vulnerable people. Right now, the Canadian data that was, I think the report was out a couple of weeks ago, basically said that 50% of our seniors have not had COVID yet.
Wow.
50%. We were thinking, oh, everybody's got COVID. Everybody that you know, young, healthy, socializing, got COVID. but the older people were still quite safe and protecting themselves. So if half of our seniors still have
Wow.
not had the infection, not even once,
Make sure
we
they're
need to protect them.
vaccinated. Make
That's right.
sure they're
Protect
vaccinated.
them, protect them, protect them, right?
Yeah,
So
yeah,
if you're around them, protect them, vaccinate them, mask, distance, all of that stuff, especially when we're getting together, like a nice social event, right? We've now
Mhm.
heard of many super spreader events again. We used to talk about that in the beginning. Now we're hearing this thing again where people within a company, for example, half the company is wiped out because of the virus. So
Yeah.
the virus is still very much so around, and the vulnerable
Airport
people are still
flying. A lot of people get it while they're flying back or flying to another country. And
Yes.
it's even us as doctor, I'm sure you've seen that a lot, Peter, but it's I got COVID twice already. I'm afraid the third time now my chance of lung COVID are just going up by what you've said. But the 2 times I got COVID had nothing to do with my work in the hospital. Okay, then it had to do with something social that I did.
Yes.
And because in the hospital, we are still protecting ourselves. This is where we follow rule, where outside the hospital, we've stopped following rule pretty
Correct.
much.
And outside the hospital, the most common thing, remember, the virus is relying on us to do mobility. It has no motor, right? So therefore, it's relying on me to come to you, Jean, and say, Jean, it's so good to see you. Okay. And then you're going to say, Peter, it's so good to see you. And then you're going to suck in all the virus. So in other words, fundamentally, all the viruses are the same in transmission. So RSV, flu, any of them that you talk about, I breathe it out, you breathe it in. Basically, that's it. So if we can interrupt that, I think that's helpful. Unfortunately, as you said, we're socializing, so we cannot interrupt it all the time. So any kind of heads up in terms of your immune system is also good as well. It's very interesting, Jean. There was a paper that was coming out about why we get sick in the winter months and why more so in the winter. Now, COVID is throughout the year, but usually flu is in the winter months.
Worse,
anyway, beautiful paper.
RSV, flu, exactly.
Yeah, it's all winter, right? It turns out in our nose, we produce decoys. We send out decoys, little chunks of material that has all sorts of interesting receptors on it that the virus would like to attach to, the virus with the keys. And so what we do is we send out decoys so that the virus attaches to those decoys and not to us. That's how smart our immune system is. And that mucus that we make, when the virus gets trapped in the mucus, it cannot move. Remember, it has no mobility. So the stuff that you hate blowing out, it's actually acting as a barrier so that the stuff is getting there. Interestingly, they did an experiment where they dropped the temperature in your nose. And if they drop it by just 5 degrees, 5 degrees, you will produce only 40% of those decoys. You make less decoys. And also, the decoys are less interesting. You put less of those things on top. So therefore, they're not so interesting. So less of them and less interesting to the virus. And that's why in the winter months, the virus is going to come in and it's able to get in and get down into our system.
Wow.
So it kind of makes sense.
Climate change in the winter.
There you go. Climate change. Yeah, we gotta keep warm. So that's why I tell people a mask is not a bad idea, right? It keeps the virus away and it keeps your nose warm and things like that. So, it's very interesting that this virus has evolved so well. It understands that we're social beings, and that's why we're going to spread.
That's where it is there to stay, and
that's right. That's why it will always win when we let down our guard. And unfortunately, this time around, even though the virus count is very high, we're not screaming about it. Before we would be screaming, take care, do this, do this, do this. We're not screaming about it.
But there is a kind of a fatigue also in the population that people are kind of questioning, it doesn't work, it's still there, it's and then it's by understanding that it is there and it's going to stay there, and after that it's about us, and what should you be doing, and obviously the knowledge are also going to evolve over time. Any of these treatments that prevent long COVID, because we've been talking about the complication that we want to prevent, the infection from happening, then not being in contact, that's the best way. Then we want to prevent the infection when it happened to be so severe. Then we know, that certain condition like yourself being elderly, having a comorbidity will increase the risk of complication. Vaccine will decrease the complication. This is all the way we have to look at it. But what about long COVID?
Right now, they're looking desperately for things. So they're using blood thinners, right, for that group of people.
Hmm.
But then they're not giving it to that group of people. They're giving it to long COVID. So
Long,
if I
yeah.
give long COVID and I don't separate out those blood clot people, the results are not going to be good. Because let's say there's two people out of the study that is blood clots, they will do fine, but everybody else will say there was no benefit. So I think right now, if we can separate those things, even if the researchers are not separating it, we can separate it so that we can offer these very simple treatments. So for the short term, I don't see any, here's the treatment for long COVID.
Okay.
I see us sort of playing with your diet. If it's the bowel thing, if it's the fatigue,
Yeah.
what should we do with the fatigue? Almost all long COVID programs will talk about deep breathing. In other words, breathe in through your nose, out through your mouth slowly to increase the oxygen levels in your body. And I think in my simple mind, I'm thinking if I give you lots of oxygen, maybe your cells will say, maybe I should start burning some fat because I have all this oxygen. Maybe I should use it. And perhaps that's how we retrain it to start going in this direction. So I'm thinking that for long COVID in the short term, it's actually up to us in primary care, in the specialty care, to look at your patient and say, what are your symptoms? How can I help you with the current medications and strategies right now that I have in my hand? Because I think if we wait for the studies to come, it'll be another
Yeah,
5
a lot
years
of
of
suffering,
suffering
a lot
from
of
all these
suffering.
people.
It's art
And
of medicine. Obviously,
yes,
when science is important, but art of medicine always have a place. It's how you use, your intelligence as a physician to really focus and be more specific. And we're not talking of artificial intelligence here, where there
we,
might certainly be a place. But
I
that
think
we
we need
use
some
the science
human
first.
intelligence
Yeah,
for a change. Well,
but
to
still.
your point though, is that they've looked at some studies and the patients said the doctor listened to me about my symptoms.
Yeah.
And that alone is a huge therapeutic benefit for our patients. And they said that because the doctor listened to me, it made them feel better. We didn't really fix anything. So if
Yeah.
they're getting the palpitations, they're still getting it. But the fact that they felt that people took time to listen, as opposed to, oh, don't worry about it, it's nothing serious, and brushing it off. So I think there's, to your point about the art of medicine. So that part, that empathy, that listening, and sort of genuine trying to help the patient figure it out, that you cannot replace with a machine or any kind of artificial intelligence. Not
Yeah,
any.
that's what the artificial intelligence doesn't have, and unlikely to have. But let's go back to the physician and the family physician. You're kind of opening me that door now where I can come back to this topic. What would you have in your experience, Peter, and what would you say that the gap to fill, let's put it that way, or optimize, because I don't like to have the approach of, yeah, you're not doing thing right, this is not, I prefer to say, okay, there are places for improvement. There are certain things that seems to be either kind of generalized where or easier to improve. Let's change our approach, let's optimize our approach. What would you say in family medicine things should be done, from what you have seen in your practice or in your conference and talking to colleague as well?
Yeah, I think this kind of group concept is very helpful. So together, okay, so whenever we're alone, this is when we feel the burden of the weight. But in group practices, as we're seeing a lot of this is coming together, group practices now with nurse practitioners, with a pharmacist that's part of the team, with a physiotherapist. So then everybody can take a little bit of the weight. So it's kind of like carrying a big, heavy sofa. You're not carrying it by yourself. You have 4 other people helping you carry. And then all of a sudden we're having a good time carrying a sofa, right? So Jean, if you had to carry a sofa, that would be struggle, right? But if all of us came to help carry your sofa, we'll be having beers afterwards. We'll be enjoying ourselves. So I think that's one way. And that doesn't cost any extra money, right? It's just tying people together. Number 2 is I think we have to see ourselves as the quarterback. In other words, we are actually holding everything together for the patient. And we're using the specialty and the x-ray technology and those things on behalf of our patient. So we're representing our patient. And I think when we feel that we're representing our patient, we're helping our patient, then the work doesn't seem like a burden. Because right now we hear a lot of physicians saying, I'm burnt out, there's too much work, there's too many diseases, too many things to look after, too much responsibility. But yet, if I were to say, come help this patient, all the doctors will go help that patient. So I
Yeah.
think if we can turn it around, instead of feeling like you're dragging everything along, you're helping that patient in front of you. So for the next 12 minutes or 6 minutes that you have, you are going to help this patient lead a better life. Whether it's talking about their cholesterol or diabetes, or making sure they get a vaccination, or making sure that, they wear a mask, and making sure that they don't breathe on their grandmother, and therefore the grandmother doesn't die this Christmas, you are helping that patient. And I think if we see that, then it's a higher calling, as opposed to, I have to go through the vaccination process, or I have to go through refilling this prescription, I have to explain the blood test. If you can explain things well to a patient, they understand it forever. And that's the beauty in primary care, is that we get to play in all the sandboxes. I
Yeah,
get
no,
to play in your lung
absolutely.
sandbox, I get to play in the brain sandbox. And I think COVID-19 is showing us that one disease can hit all of those places. So therefore, primary care would be ideal, because we look after all of those things. So we know about puffers and stockings and all of these other crazy things,
But
whereas
I think,
other
Peter,
specialties may
you're
not.
sending us some very important message here for family physician, but in fact, all of us. What I've learned taking care of chronic disease such as COPD, it's having a team, but being also a good team player.
Mhm.
And you can be quarterback. It doesn't mean that the one catching the ball is not important.
Right.
It's quite important, because if you're only the quarterback and you keep pitching and nobody is catching the ball, then your team is not going to win. And the patient feel it. My experience, and I don't know about, I'm sure you've been to, the patient feel confident because he knows that it's not only a matter of doctor. It's he feel good, and he feel that he's getting the right care. Is feel that you're listening, okay? And that's also the thing, listening to the patient, because sometimes it's in the detail that you're going to be able to personalize your treatment to the patient. Then those two things are quite important: team, being a team player, obviously, listening to the patient, listening to the detail, because when you don't have the magic solution, we're not the surgeon. And you cut, you remove, you solve the problem. Things are a detail of, and as you listen and you take care of these detail, you can make the difference of the life of these patients. And the family physician is in the ideal situation to do that. And not that the specialist should not be doing,
Mhm.
everyone should be doing it. But what you're saying is that the family physician is in that situation where he can do it even better than anyone else, because I don't want to hear about this, this is not my specialty. But not hearing about this could prevent you from understand what is going on, okay? And the
Yeah, very
family
much so.
physician
Yeah,
can
very
do
much
it.
so. And to your point about how, if you're the quarterback, it doesn't mean that you're bossing everybody around. You're part of the team. I think John Wooden, the basketball coach, the famous basketball coach,
Yeah.
said that if you think about a car, everybody thinks about the engine, like the best star player is the engine. But he goes, what happens if you're missing the little screw that's holding the wheel on the car? If
Mm-hmm.
there's no little screw, then the wheel falls off and nothing is moving. So that's why his point was that everybody plays a role, including the patient, right? The patient is very important to this.
Patient
The
center.
pharmacist is important. The primary care doctor is important. The nurse practitioner is important. The person taking the blood samples is important,
Yeah, yeah.
because all of those people are trying to help that particular patient. And I think if we have that, they always say patient-centered approach, right? But I think we just need to care about the patient. Because
Yeah.
if you care about the patient, because that's somebody's mother or grandmother or sister, and if we care about the patient, then the work doesn't seem such a burden. When
Yeah.
you're sort of looking at it as an assembly line, it's everything is a burden. But if you look at it as a person that has a life that you're trying to protect and allow them to grow and be well, I think
Then
we're willing to fill out the paperwork or get this medicine or do this or make sure we spend the extra time to listen. And I think in particular, COVID has taught me that it was a disease that we didn't understand very well, and the patients didn't understand it. And then we started to understand, and then we could explain it to patients. And then the long COVID, we don't understand very well, but now we're starting to understand that there are things that we can do. So it's actually a very empowering disease, because it showed us we went from nothing to all this information that we have
in
on
few
it. And
year
then
only.
Right. And we have now
Not in a
strategy.
lifetime, in a few
We
years. Yeah.
have treatments, we have vaccines, we have
Yeah.
all these things. We know how to prevent. So now all of a sudden, within a very short time frame, I guess in a sense, the whole world came together. And so therefore, we now have an ability to contain and control. We can still do better, but at least I think I'm optimistic that any future
Yeah.
things that come up, we should be able to use this same mechanism and even improve it. But the whole idea of AI is good is because it keeps reiterating, right? It checks what's to do and then keeps going in circles and then making it better and better. And so that's what we're doing, is that how can we do better next time around? How can we make sure that we don't have lockdown, for example? How do we make sure the vaccination is good? How do we make sure the elderly are protected? So I think each time we go through this iteration, we're getting better and better. And I look at it as every time I see a patient, I can make it better and better. So did I
Yeah.
explain it right to the patient?
And
Okay,
that's the
next time I'll try.
lesson learned, in fact, that we can apply beside and beyond, COVID, and the lesson learned over these years and in our practice. But I think what applied to COVID and long COVID will apply the same to other disease, and in particular chronic disease. And if we do that, then I agree with you. We're going to feel better about what we're doing, even if it's tiring, because it's more tiring now. It's quite demanding. But at the end of the day, you still have the satisfaction and the patient being
Mhm.
part of it as well. Peter, we've been talking of the past, we've been talking of the present, we've been talking of the future in terms of what might be coming on, with the treatment of COVID, prevention, treatment of long COVID. If you haven't been able to prevent the infection from coming, research is going to be key. But while we're waiting for that research and these new knowledge, obviously we have to apply what we know, even though it's basic, and then we have to keep repeating ourselves. Let's do it. Let's do it as a team. And the patient is part of the team. Let's listen to the patient. Then what is it on your side, okay, from closing here and work and research? Are you doing any research or any work on the clinical side now that you'd like to share with us?
Yeah, I think right now I'm looking into sort of this subdivision of long COVID, and therefore we can see what treatments we should be using, either things that we have right now available or things that will be to come. And so I think I'm looking forward to the idea that primary care has all of these patients. We're now subdividing them, and then we've got research that will help us treat those particular patients, and then we can offer actual treatments to them. Right now, I'm just sort of saying, okay, let's try this, let's try this, let's try this. So it'd be very nice for the studies to say, look, we did this on, through 2,000 people, and, 80% of them responded. So that's what I'm hoping for. But in the meantime, I think in primary care, patients trust us. They really do trust us. And so if we can just be a little bit more empathetic. I know it's a lot of time and a lot of effort, but if we can just have a little bit more empathy and understand the amount of suffering that goes on with these people, then we make that therapeutic alliance so much stronger between ourselves and the patient. And even if I don't have something that I can give them a magic bullet to fix it, somehow we actually make them feel better. I've had patients where they come in, we talk about things and things like that, and I haven't done anything. Like, I didn't give them a pill, I didn't
No,
fix
exactly.
anything, and yet they leave there feeling better. And so I think that's the joy of being in primary care, is that we might not have all the answers, but we're there to help our patients, and they actually truly do feel better after they see us. And so, yes, it takes time. Yes, we're all exhausted, but just sort of feel the reward that the patients are doing well and that we're able to help them continue on to see their grandkids, to go to graduation of their son, because we prevented some disease or we've managed it, we've contained it for them. And in
don't
primary
forget
care,
grandma. Don't forget
yeah,
grandma at
that's
the end too. Okay, then
yeah,
not those.
always grandma, always grandma. Everything, and everybody kept asking me, "What about grandpa?" We said we don't
Yeah,
care
where
about
is
grandpa.
grandpa and all of this? Okay, let's be modern, okay, and don't forget grandma and grandpa,
That's right.
please.
There
Okay,
you go.
that's very
Combination.
important. But Peter, other than listening to this podcast and listening again to this podcast, is there any link, any website or anything you would recommend for the people out there listening?
Yeah, I think right now, I think your podcast is great. So I think I've learned a lot from your other podcasts that you've done. I think listening to podcasts are great because what you end up doing is you end up picking up all this knowledge from others, right? You think about this virus, right? It's now so evolved, it's down to just blueprints and keys. Now imagine if we listen to other people in other specialties. In primary care, we listen to cardiology and endocrinology. And then what we could do is start integrating them
Mhm.
together. So in our mind, we can start pulling it together and say, hey, the same process that's happening here, inflammation is happening here. The same process of autoimmune disease is happening here and here. So we can actually see that there's many commonalities amongst the diseases. So it's actually easier for us to manage these people because we can see the pattern. So I hope that primary care will see their huge value as the cornerstone. Actually, it's the cornerstone of medicine in terms of keeping everybody healthy and preventing diseases. And imagine if we can prevent a whole bunch of diseases, heart attacks, strokes, diabetes, COPD, lungs, and so on and so forth, then the population will be much
Yeah.
healthier. So primary care is actually able to save the healthcare system. Everybody keeps saying we have a broken healthcare system. It's only broken because we point out all the cracks, right? Whereas if we talk about all the strengths and we play on the strength, then let's not keep telling people your car is lousy. Imagine if I came to your car, Jean, and I said, your car is a 1967 Mustang, let's say. Oh, look at all the cracks on the bottom and your tires are old and the brakes are terrible. Instead, we look at your 1967 Mustang and we say, beautiful car. So why don't we do that? We say, look, primary care is beautiful.
I agree
Right?
so much with you, Peter. And listening to you, I'm sure that hopefully there's going to be a decision maker and some people from our government that are going to listen to the podcast. And that last part about the crack, I like it very much. That not that you cannot improve the crack, by the way. There's always place for improvement, but then not only focus on this, but people that have listened to you. With some people are probably thinking about going in family medicine now. I'm pretty sure. I hope this is gonna happen. I really thank you very much, Peter, for this very entertaining, but also how much we've understand in the deep some aspect of this disease of what we know, and about the family physician also, and a thing that we can continue to do, and other thing that we can optimize, improve in our practice. Thank you very much. That was Peter Lin.
Thanks very much, Sean.
Thanks for listening to the Expand podcast. Stay tuned and listen to other episodes on chroniclungdiseases.com/podcast.